Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast podcast. My name is Terry Fletcher. We made it to episode 40, so I'm pretty happy to say that we are been going strong for 7 months now. We are at the end of July, which is just exciting for me since we started in November of last year. I've actually been searching out some podcasts myself, and there's really nothing like us in the genre. But what I did notice is that a lot of podcasts go for 4 or 5 episodes and then they don't continue. And so we've been very lucky to be able to continue. We've been nominated for a People's Choice Award for podcasting, which is very exciting. And right now we are number 1 on the medical coding and billing search for iTunes, Stitcher Radio, and for TuneIn. And you can also find us on YouTube and on my website at terryfletcher.net. For those listeners new to the podcast, first of all, thank you for searching us out. We appreciate the downloads. And I know my producers and we work very hard to give you a quality product each week. And I actually think this is the last day to vote for podcast awards. So if you go to podcastawards.com and you still want to vote and nominate, you can do that. So we are in 3 categories of business and health, and then just the general podcast award genre. So thank you again for doing that. We appreciate it. So today it was what we call Top 10 Tuesday, meaning that the top 10 coding and billing questions that I've got throughout the month you'll be hearing about. However, as you saw in the episode notes, we've had some breaking news from Medicare or CMS, Centers for Medicaid and Medicare. And it's a little disturbing. I know it's a little daunting at first because of what they are proposing to take place as of January 1st. So I need to address that. I need to address it mainly because when I saw it, I'm just beside myself. Now, I am a physician advocate. There's no question. I also audit for Medicare, I audit for private practices. And so documentation for me is just a huge issue, whether it be correct or incorrect or something that you need to really perfect to make sure you can support what you do. And it's also cumbersome. It's tiresome. It is an administrative burden, but you have to be able to support on paper what you're going to do with the patient, not only from the intake until they are out of your practice. Well, Medicare is saying some proposals here that are interesting. And if you haven't had a chance to hear about it, this is what I'm here for. I'm here to bring you up to date, making sure you understand what's going on. I may be ranting a bit, so I apologize in advance for that, but you have to hear it. And hopefully you'll understand some of the disdain in my voice probably. I'm going to give you the cons for it, there's no question, but I'm also going to give you some positives. There are some positives within the proposal, but I think the negatives, unfortunately, right now, for me anyway, are outweighing those. And so you need to be a voice. You need to make sure that you're talking to your associations. When Medicare drops bombs like this, basically they say, okay, and guess what? You've got 60 days to respond. And it's amazing to me how they start off saying we've taken over a year to, try and figure out how to do this. And now we're dropping it in your lap, but you only have 2 months to respond. Which means in 60 days, you basically have to read it, understand it, basically sit with it for a little bit. Always do that 24-hour rule. I know I have to, otherwise I get pretty hot about things. And then you have to come back and then you have to have a mindful approach on how you're going to respond to it. Well, this came out on July 17th. And so as we're, looking at this, actually, let me back up. July 12th, it actually was dropped. And July 17th is kind of when all heck broke loose. See what I did there? I'm watching my profanity because I do not edit in beeps or anything. But I'm telling you, I did rant about this and it wasn't pretty. And so we really want to take a look and see what's going on. Just if you haven't had a chance to hear all the details, this is where I'm going with it. And you're going to hear some sidebar from me as well, only because I'm coming to you. I've had 30 years in the industry, and not just as an educator and an auditor, but as someone who is such a passionate person about the medical field. And I love what I do. And not only that, I love making sure that physicians not only are compliant in their practice, are making sure that their documentation can stand above reproach, but that they're also maximizing their reimbursement for what they do. And so when I feel like there's been a kick in the gut to that process, it definitely makes me, pause for a second and say, okay, what can I do to bring this to their attention and make sure that they're aware of what's going on? And I can't urge you enough that you'll need to comment in this 60-day period. Okay, but before we get started, as always, the Codecast podcast is brought to you today by Advanced MD, spotlighting telemedicine as a solution that's proven to boost patient engagement and bring in new revenue streams for your practice. AdvancedMD.com. And Healthcare Executive Network is the fastest growing community for healthcare executives and their trusted partners. HealthcareExecutiveNetwork.org. Okay, so as we get started, before we do, I actually was remiss last week, and I apologize for that. I tell you, I don't know what I'd do without my music and content producer, Disassin, because he listens intently every week, not just to voice inflections, but if I tell you I'm going to do something and then I miss it at the end or something like that, because I get on a roll. When we podcast, especially when you podcast as the only voice on the show, sometimes you get on a roll and you think, oh, shoot, I forgot to do that. And so I did forget a code question last week, and we are the Codecast podcast, so I always need to include a coding question. So this week, the coding question comes from one of my Chicago clients, and it says, Terry, in which situations would a coder need to use modifier 24 on an E&M service? Okay, so remember what modifier 24 is. First of all, it is an unrelated evaluation and management service by the same physician or other qualified healthcare professional during a post-op period. Okay, so to ensure proper coding, a couple of things that coders need to understand before you append that modifier. So sometimes you'll need to tell a payer that an encounter is for something other than follow-up for a procedure that has global days. And remember what global days are. It means if you have a major surgery, and you'll see it listed, the global days, if it's a global service or not, on the edits and on the Medicare fee schedule. What it means is that the global period is the day of, and then 90 days out from the procedure, or 10 days, okay, it depends on what it is. So for example, laceration repairs would be 10 days, but an appendectomy would be 90. So major surgeries are 90. And what it is, you append this modifier to the E&M or the visit code when a patient comes in during that 90-day period, during that global period, when you're trying to show them that there was something wrong with the patient that you needed to evaluate that had nothing to do with what the surgery was for. And so that means that, you're basically seeing a patient for a completely unrelated visit. And unfortunately, this is one of the number one RAC audit issues where a lot of practices or a lot of physicians say, well, I have this happen all the time in cardiology, for example. Got a patient that just had a device implant, so a pacemaker, and they happen to have the diagnosis of hypertension as well. And so they bring them in for an office visit, they check their device, they talk to them about their wound site, and they're still in their global period. But because they have hypertension, which is well controlled with medicine, they go ahead and slap a 24 modifier, let's say on a 99213 or 214 code, which is an E&M follow-up visit code, and then they try to bill for it as an unrelated service, which is incorrect. Unless you're addressing a new problem or an exacerbation of an existing problem, that is not an appropriate way to use a 24 modifier. So when could you use a modifier? Well, here's one. So let's say a patient had a total right hip replacement during the post-op period, but then the patient fell, injuring his right ankle, and the patient does an exam of the right hip to make sure it's okay, but also does a history and exam of the left ankle. So now the 24 modifier would have the ankle injury or the ankle soreness as the E&M service that day. Or let's say that the patient has a right toenail removal, HELIS. And the post-op period for that is 10 days. Let's say 7 days later, the patient returns complaining of his left toenail being painful. The physician does the history and exam and decides the left toe is now infected and gives the patient antibiotics, instructing him to return for another week. See, now that is an exacerbation of that problem. It's not something that is just a regular routine patient recovery. So you absolutely can code for that with a 24 modifier. In the scenario I gave you for the device, let's say the patient had hypertension, but the patient was well controlled. But let's say today, when they came in for their post-op visit, during that visit, the doctor noticed that they had a very high blood pressure. They were concerned about also some changes on their EKG, and the doctor wanted to modify medication, and that's what the brunt of the visit was for. It wasn't about the device check, or the device implant, I should say, the surgery. Then now you have an argument at least for the 24 modifiers. Just be careful when you're using that, because you cannot put it on routinely during the global period just because you want to get paid for that encounter. So that's really a big issue. Okay, so now our breaking news. Okay. So probably the biggest change in 2 decades is the proposal that CMS plans to redefine the documentation requirements for E&M coding in 2019. So E&M, evaluation and management, those are our office visits, new established patient consults. They don't recognize them anymore, but same concept. They're proposing to forego the 95 and 97 guidelines. And that's really what we look for right now when I audit a record, or when your physician chooses how to choose a level of service. And it's being reported, this new proposal, as a quote unquote simpler model that will eliminate the need to redocument prior visits, redundant information, and focus on medical decision making. Okay, I love that part of it, but wait, there's more to it. So this will require significant re-education to physicians and mid-level providers on really how to document. Now, I know some of my client base, which I believe will basically say, oh, about time. But wait, they will be surprised at the proposal when they realize the impact of reimbursement this will have. And hopefully you go running to your specialty and say, you need to stop this madness right now, because there's no open discussion. The transparency isn't there. And really, this is something that can't be implemented in less than 6 months. But the other thing that you need to understand of what CMS is proposing here is they want to blend an E&M service into one specific RVU. So the documentation is based on the ability that any provider can get into the electronic medical record to find additional information other than what's noted in the patient's specific note that day. Malpractice may also become more of a problem with less documentation, especially for those complex patients. And CMS has added many new modifiers to indicate specific specialists, even changed prolonged care. So podiatrists are going to have a bonanza on this, because they basically are going to get paid the same way as somebody who's taking care of somebody with congestive heart failure. And also billers are going to have to take a lot more time, and coders, to enter all the modifiers into the system. So there was something called, and here, let me preface with something. So one of the things that drives me kind of crazy, I always see how people are out there kind of marketing things where I'm thinking that's genius, where they're playing to people's, I don't want to say their sympathies, but to their weaknesses. And they're playing to them in a point where if you say something against it, it means that you're a bad person, even if you don't believe that it's true. And so, whenever I pull up my computer, it always says, right when I turn it on, my internet service says, do you want to have a faster modem or something like that? And if you say no, it says, or do I want to stick with my slow modem? Basically, it says, do you want to be smarter, or do you want to be an idiot? And so if you don't want to take on their service, basically you're clicking I want to be an idiot mode. And that's not what I'm trying to do. But it makes you feel that way because you're not buying into what they're saying. And so what I'm saying here is that when they're talking about this, think about these buzzwords here and think about how this would make your physician feel when they hear it. They're talking about simpler model. Then they call it patients over paperwork. They're saying that this is going to basically change Medicare to modernize Medicare and restore the doctor-patient relationship. It's going to give patients the quality care that they need. I mean, do you see where I'm going with this? Think about this. You're a physician and you're looking at your reimbursements changing because they now want to go to a 1 RVU code. And now they're saying, oh, well, this is going to be some kumbaya moment where you're going to basically be sitting around the fireplace and, singing songs together. This is where you have to really understand that this is not This is not the best thing for certain physicians, especially the specialists. And when they talk about restoring the doctor-patient relationship, think about your physician wanting to not fight against it, but be heard against what this really is. So they put out a Dear Doctor letter, and that's the other thing. Dear Doctor, could anything be more sweeter than that? No, it was a statement saying, you better comment before September 10th, or we're going to roll over you with a pretty big bulldozer. And so this Dear Doctor basically talked to physicians who they call stakeholders. Take that title seriously. You're a stakeholder in this. If you have a percentage of Medicare patients that's over 10%, this is going to affect your practice. So today it says today's proposals deliver on the pledge to put patients over paperwork by enabling doctors to spend more time with their patients. Physicians tell us they continue to struggle with excessive regulatory requirements and unnecessary paperwork that steal time from patient care. Now they're saying the administration has listened and we're taking action. The proposed changes to the fee schedule and the QPP, which is the quality payment program, they're saying they're addressing these problems. They're going to streamline documentation. And then basically now the doctors can just take care of patients. The problem is the fee schedule that they dropped shows that the doctors basically will have to fill that quote unquote extra time with basically more patients. Otherwise, they're not going to be able to make up the volume of reimbursement they're losing. Also, as I reviewed these changes, CMS is stating that the proposed fee schedule would help to free electronic health records. To see the words they're using: patient over paperwork, quality care, freeing EHR, modernizing healthcare, restoring the doctor-patient relationship. I mean, people, you have to understand that even though this is, how can I explain this? You can hear my frustration. And that's why I like to podcast, because I can kind of vent and just so you can hear it from somebody that is in the industry. I'm in the trenches with you. What you're looking at here is basically a way for CMS to change their agency, to shrink their agency, to help their processes. I don't see how this really changes what the physicians, are going to do. Because first of all, they said, okay, well, clinicians could save an estimated 51 hours a year if 40% of their patients are Medicare. Okay, well, if you're a specialist, and they said, oh, by the way, this is only going to be a 1 to 2% reduction. If you're a specialist, you're looking at anywhere from 22 to 37% reduction. And quite honestly, when you do the math, it's 12 minutes a day. 12 minutes a day if you look at the 51 hours a year based on what a typical practice is with a 40% Medicare patient load. 12 minutes a day to lose anywhere from 22 to 37% reimbursement on your E&M codes. Is that worth it to you? I mean, you have to look at the reality of the reimbursement concerns here. If you're a specialty physician and you're taking care of sicker patients that need more time, effort, and higher levels of care managing their complex issues, you're going to get paid the same amount based on a level 2 documentation of a new patient visit as a patient who walks into a primary care physician's office for a rash. Same amount. There's not going to be a change. Also, what's going to happen is that, remember what happened when Medicare decided they weren't going to pay for consults anymore? Many, I would say a big percentage of the commercial plans said, we're going to follow Medicare's guidelines. We're going to follow Medicare's lead. And so if that happens and you've got commercial plans now following Medicare's lead, think about on top of that, they just comment on this for 40% of Medicare, but you've got commercial plans now that are following Medicare's lead on policy. And so now you're going to get taken down again, where they're going to say, okay, well, if Medicare can do a 99203 only, and they can just do 2 levels of an E&M service, sweet, that's what we'll do. And so that's really going to be a problem when it comes to providing that care that your patients need. Again, especially if you're a specialty physician. So here's where I have the issue. And this, I think the American Hospital Association stated it best, and on their kind of policy, or their statement, I should say, regarding the proposal. They said, providing substantially less ability, what this proposal could do, to distinguish evaluation management codes for different levels of resource use and intensity of services means that physicians who provide care for a disproportionate for a disproportionate number of high acuity patients would consistently and unfairly receive underpayment. And I just could not agree more with that statement. So the AMA president, Barbara McGaney, she actually came out and said that the AMA is evaluating how this proposal will affect patients, especially those with complex conditions, and they're going to carefully evaluate the impact across various types of patients and specialties. So that's one thing. But please do not leave it up to the AMA. Don't leave it up to somebody else will be looking at it. Because for some doctors, the system is just going to be too simple. With one payment level, no matter the complexity of the patient, ACC, American College of Cardiology, Community Oncology Alliance, they came out, and you're looking at drastic cuts. If you're an orthopedic practice, if you're a pulmonary practice, if you're a practice that is a specialist, nephrology, rheumatology, think oncology. You've got a patient that's coming in and you're treating them for brain and lung cancer, and you're going to get the same amount of money for a new patient visit as somebody who's coming in for a cold at a primary care office or as an established patient visit. That effect right there, you're looking at, let me just give you an example. So an oncologist, I did a look at this for critical evaluation and management of more complex cancer patients. So usually they bill anywhere from a level 4 to a 5. And let's just say a level 4 new patient visit. Well, if the proposal goes through and you're stuck at not getting anything more than a level 3, they say they're going to adjust the payment to $135 instead of $172. And so now you're looking at a 22% cut. And let's say that you're looking at an established patient visit. That's going to go from $148 for maybe a level 4 to $93. It's just insane what they're proposing here. And so this reimbursement situation is similar for many, many specialists. And so there was just some comparisons on what they're looking at. And I wrote an article on this. Actually, I have several articles coming out on this. I'm being asked to be a loud voice on this. So ICD-10monitor.com. I have an article coming out. When you listen to this podcast, you'll see it drop this week as well, or next week. So just keep looking out for that. And then also on Medicare or medical economics, they've also asked me to weigh in. So I helped write an article for them. And then also Healthcare Executive. I've got so many articles coming out on this, and plus the podcast and you'll see some things up on my website as well, because I tend to rant on this issue. I just don't want to see physicians get burned on this, because CMS is trying to lessen their administrative burden and say, oh, look what we did. And so I do now the positive. Okay. So I do appreciate the effort CMS seems to be making to try and streamline the burdensome task of evaluation management documentation. It's not taking all the provider's work and patient type into consideration, though. And this is what could potentially kind of be the demise of the Medicare system. Instead of making a proposal that has more holes in it than positives, and to make a push for it to become effective in less than 6 months after the proposal, in my opinion, they should be at one of many potential proposals, and with time open for discussion, not just the 60 days. Clock's ticking already. A request for proposals with industry experts, auditors, educators, and then make a thoughtful decision. This issue was addressed earlier in the year. I'm sure you saw that they were saying, we really need to make a change. We need to start getting on the bandwagon to really, talk to physicians, bring them into the discussion, and figure out how we can move on from the 97 guidelines. I couldn't agree more, but you don't do it in 5 months. You basically have to bring everybody into the discussion, and AMA is really made up, and CMS is really made up of primary care doctor influence and ER doctor influence. If you look at the video they put on YouTube with Selma Verna, which is the CMS administrator, they really didn't understand the coding and the documentation process. If you just look at that, one of the things that was said is, well, the 99201, and she didn't say the code specifically. She said level 1. She said that's usually for non-physicians anyway. Okay. Well, if you're talking about the new patient level 1, that's not a true statement. The established patient level 1, 99211, that is a true statement, but nobody cares about that code. That's a $24 code. And that's only performed by non-physician practitioners. Agreed. But the level 1 new patient visit, there has to be a doctor in the room. That's a straightforward visit worth almost $45. So this is where you hear some of the things that they're saying, and you're like, do you even know how the system works? Now, in saying all this, I realize that they are hoping to lessen their documentation burden, regardless, of what it does to physicians. And I know there's some physicians out there also very much proponents of the proposal, hoping to lessen their documentation burden. Now, the one positive I do see is the fact that they are trying to focus on medical necessity. And, I consistently document and I consistently educate on really focusing on medical decision making. But you have a voice as a physician, and you really want to make sure that you are writing to your specialty societies and associations, and that you act before, you really talk to them and act before September 10th. One of the things that I always hear is change is good. No, change is not good. Good change is good. Change just for the sake of change is bad. Ask anybody. One of the most recent things in the news, ask IHOP. They went to IHOB and then went back to IHOP. Think of Coca-Cola. How many years ago did they try to put out the new Coke and went back to the Coke Classic? I even just recently saw Range Rover, where they used to, they put out the new one, which was a smushed vehicle, and now they've got back to the Classic. Change is good as long as it makes sense. And right now we're not seeing where this makes complete sense. And even something as simple as one of the creative outlets that I've been doing is my waiting room designs. And I see a lot of people that now design all digital. They put everything on the computer, which is cool to look at, but I do them on a sketch pad. And so I have a waiting list right now. They just want to see that raw sketch, the visualization of something coming from an idea, coming to a pad, then going to a rendering. And so I'm not saying everything is old school. All I'm saying is that if you're going to make a change and you're going to say it's good, make sure you get input from people in the know, from the industry, not just saying, we're a bunch of executives sitting at Medicare that we decided this is what we're going to do because the political administration said we're going to make a change. So again, not all change is good. Good change is good. So we have to really look at that and make sure that, you are contacting your associations. Please Google on the search for the changes, and you want to Google, and this is how you want to look it up, CMS proposed change, and you can put YouTube, because then you can see the video, which is about, I think, 18 minutes. And then they have the other administrators, I should say junior administrators, that are commenting with it. But it's a good visual to watch. And it's the whole Dear Doctor letter thing. And then also you can see it just in every possible news feed out there. So make sure you look at it. We'll have it up on my website this week. I wanted to make sure I got to talk about it before I put the link up there, but we will have that up there this week. And so hopefully you got something out of that. I apologize for the rant and just, going on about it, but you can tell this is a really hot topic right now. So we really want to make sure that we're understanding it, we're listening it, we're prepared for it, and that your doctor is also on top of it. Make the time to respond. Time is ticking, so you really have to make sure you're doing that. And what's interesting is September 10th is right around the corner, okay? So we want to thank Medical Economics, Smarter Business, Better Patient Care, medicaleconomics.com for the business of medicine, digital magazine, and health IT. And remember, I'll have an article up this week on the new Medicare proposal. And our final sponsor is Keck Medicine of USC, over 500 nationally renowned physicians at a leading academic medical center, keeping you healthy, on track, and doing things you love. KeckMedicine.org, ranked in the top 50 hospitals in the country by U.S. News and World Report. Also, for those of you that inquired about being a sponsor for this podcast, thank you so much for your continued support. Please email me directly at terryfletcherccc, so coder at gmail.com, or at terryfletchercpc@aol.com. Whatever works for you is great. And also, give us a shout out on social media. TerryCoder1 on Twitter, and then I'm at TerryNCA on Instagram, and then also I'm on LinkedIn. Connect with me on LinkedIn. I post a lot of times on there, just some really business thoughts of the day. And also for those of you that are in Southern California, I belong to an organization called Women in Healthcare Administration of Southern California. And I've been hosting a couple of networking events. If you want to come and meet me and talk about, anything that has to do with healthcare, I would love to meet you. We had a wine event recently that was very fun, very networking. We had about 40 people come into that. And then I have a new event coming up, and it's on August 15th in South Orange County, and that is our business card power breakfast. So we're going to meet at 7 a.m. and just, get together and have some, discussion about healthcare. And I have a little gift for everybody who shows up. So you need to go to the WA website. It's WHA SoCal and sign up for it. So, because we actually limit that one to 10. So we actually hope to see you there. So again, everybody, thank you for listening in today. If you get a chance to vote for us on the podcastawards.com, please do so. Rate us on iTunes and any platform that you're on. And again, we really appreciate all of the listeners. So thank you again, and have a great day today. Just make it a great day.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.